My name is Sally Alrabaa. For the folks I didn't meet yet, I think, John, how are you?
Hi.
Yeah. Today we will talk about infections in solid organ transplant. This is a huge topic. We're going to try and touch on the most important stuff in this coming hour or so. I guess, we have to go through the basics and then mention some common syndromes and frequent offenders but then as you go through your training, you will discover that this is just the tip of the iceberg. Okay, so good. Can everyone hear me okay? All right. So learning objectives for today. Number one, understand that the immune system works as a continuum. And in solid organ transplant, in those recipients, any part of this continuum can be affected. So when we say they are immune compromised, it can be, basically all levels of their immunity is affected. We would like to know the main types of infections occurring in solid organ transplant, their timelines after transplantation, and also be familiar with the frequent offenders, the microorganisms that we commonly see after transplant. We want to understand the general approach of diagnosing and treating solid organ transplant infections. Maybe a little bit different and aggressive than immune-competent individuals. And then a follow-up lecture for this lecture, which will happen sometime during the year, is the importance of planning ahead, which is the concept of screening and prophylaxis. So if you know what kind of infections and syndromes, and maybe we can do something about it beforehand. Just a review, when we say lines of defense are a continuum, we talk about, innate defenses, your skin and mucous membrane. People don't think that people who have issues with skin or their mucosa are immune compromised, but they are. So innate immunity, phagocytes, cells, and transplant can affect all those, your innate immunity. And then, of course, your adaptive immunity, B cells and T cells, these are where most of the anti-rejection medications work. Infections depend on what we call the net state of immune suppression. So transplant recipients are maintained on these anti-rejection medications for the graft to work, but it's a fine balance. You want to prevent rejection at the same time. You don't want to overly immune suppress to cause infection. So if the level of immune suppression increase, you will tip the balance towards infection. So when we see these patients, we usually look at, to try and just understand the level of immune suppression, what medications they're on, what doses, do they have other issues that can tip this balance towards infection? Do they have indwelling lines? Are they malnourished? That's a big one. And if they have any metabolic issues, or they have uncontrolled diabetes, or are they have this chronic renal insufficiency and chronic anemia state. But also an important thing we look at is what we call immune modulating viruses. Sometimes if the person has reactivation of things specifically like CMV, that will actually make them even more immune suppressed. So as you can see, it's not really easy to judge how immune suppressed they are, but if you start there, you can have a rough idea. So epidemiology, causes, where these infections come from. So epidemiologically speaking, the recipient can go to transplant harboring some sort of an infection. And that's why we do pre-transplant evaluation. You want to know if they're, they have to have this transplant, maybe life-saving, but they have this thing. So you need to look at their history. What did they go in with? Next comes complications post-op, right? The immediate post-op period is, it can be related to surgery, it can be hospital-acquired. And then if everything is cool, they go out to the community. It can be community-acquired, can be reactivation of all things, opportunistics. Last but not least, it can be donor-derived. So when you go see a patient, you're thinking maybe they had infection. It just helps to be a little bit organized. Okay, was there anything going on? Did anything happen post-op, and so forth? Causative agents we encounter frequently, all classes, bacterial, fungal, viral. Some of the common ones, and the ones I put their names here are just because of how common they are. So we want to be familiar with those. Candida, Aspergillus, Cryptococcus. Viral category, CMV. That's one of probably the major viral infections reactivation that happens in this category. And then of course you have your parasitic that the last class, your pox, bronchiolitis, and even Chagas has to be in the back of your mind. As I said, there is a lot of efforts for screening and prophylaxis. We'll talk another time, but that can also affect this epidemiology, because if somebody is lacking a certain prophylaxis, or if they are on prophylaxis, then it may just change tip the balance a little bit. So evaluation should take into consideration the time lapsed since transplant. It does matter when they got their transplant and how far the infection happened. Their exposures. I can never forget the heart transplant guy who used to drive garbage truck, and he was told to change his occupation. He didn't, and came up just with a big mucus sitting on his lung. Anyway, digressed. Exposures are important as any infections we deal with, but specifically important in transplant. Receipt of prior antimicrobial prophylactic agent, how compliant they were. Also, if how is that graft functioning? Yes, we gave you a liver, but is it, what is the status of the graft function? And again, overall immune suppressive status, which we talked about a little bit earlier. So this is a nutshell, So if I ask the group, if we're gonna talk about timeline, what do you think the kind of infections you may see in transplant recipients that first month after transplant?
Hospital acquired, but
yeah, your standard surgical complications, healthcare associated. Also, bacterial infections tend to be the more likely causative agents, and they have a little bit more tendency to have maybe resistant pathogens, because the nature of the beast. These people have been in and out of hospitals. They got oral, genital. In this period of time, some of the donor-related transmit infections may be evident early on. The classic example, when you take a kidney, maybe, and person had a UTI, and most the frequent one is really actually lung, because you take a lung from someone else, and donor transmitted infections have always to be considered. It got disconnected.
Oh, sorry.
It's not sharing.
Mm-hmm. Oh, it's sharing the wrong. Oh, no. The Wi-Fi went down? Is that what happened?
Maybe, because it just everything blanked for a minute, and then
Did somebody change the power? Well, it's plugged in, so
Yeah.
it shouldn't always.
yeah, just what they call it. This is happening.
Why does it keep?
Oh.
It's like almost like it keeps trying to like switch. I think it's this coming loose.
Yeah. We got it. There we go.
yeah.
Please don't even work there.
Because when you unplugged it that one time, that's
Yeah.
when it went black for me.
Right.
That's why I wonder maybe the connection with the HDMI is unstable,
Mhm.
and that every time it gets unplugged, it's like toast.
Yeah. There we go. Okay, sure. Yeah.
Okay.
What's the urgent? She sent like 7 messages.
We want this stuff.
On who? All right, now we moved on from the first month post-transplant. Then we look at the next period, which is, after month 2 to month 6. What do you think happens during that period of time? Okay.
Opportunistic infections.
Why?
the level of immunosuppression starts kicking in.
Yeah. So this, the months that follow, months 2 to month 6, that's when suppressing dosing is being adjusted. People usually start with high doses. They want to make sure that the graft functions and that there's no rejection. So the level of immune suppression is probably highest during that period of time, and that's when you will start seeing some of your opportunistic infections, PGP, Endocarditis, CMV is a big one, Toxo if they're not on prophy, and CMV, of course, people usually are on prophy, but sometimes it can still happen, and sometimes people don't take their prophy. Invasive aspergillosis also can appear during that period of time. Part of the level of immune suppression. Later in life, after 6 months, what happens? Now you have what? Now you have 2 groups of people. The lucky ones who everything is great. The immune suppression now is being, weaned to a maintenance level. They're so having some of their immune system back. And then you have the unlucky ones that they just are struggling. Now they're being reinducted with all kind of immune suppressive meds and so forth. So if they are the lucky group, then you probably more likely to see community acquired, right? Your influenzas, your COVID, your UTIs. If they belong to the highly immune suppressed, then you have to be careful about the OIs, the opportunistic infection, and then zebras start happening. That's when it can be anything. Typically, the heart, kidney are kind of, less problematic with infections, liver in the middle, and then you have your pancreas, lung at the highest. You'll have a lower suspicion that, what's bringing them back is an infection, and so forth. Also, after the 6 months, you have the herpes virus activation, specifically shingles. You may see zoster. They come in, they have a funky rash, sing zoster, and then by almost 1 year, that's when, if they're gonna get lymphoproliferative disorder due to EBV, that's when it may start. You have to consider that in your differential for fevers, lymphadenopathy, and so forth. Now, just one thing to say, even, your perfect kidney recipient who is maintained in low level of immune suppression and all that, and you think they're doing good, they are still overall immune suppressed, and you still have to keep an eye on those individuals. So I wouldn't, at any one point consider them with an intact immune system. So opportunistic infections can still happen on people who apparently doing well on low levels of immune suppression, because can you really ever measure accurately how immune suppressed they are? No, it's just an estimate. Now, I put this slide here because you're going to see it anywhere you go. You open Mendel, it's there. You open it's this famous slide that discussed the timeline post-transplant in relation to infections, or infections in relation to timeline. So it disappears, but it comes back only here.
Not sure.
Something's connecting and disconnecting.
I was about to say, you can hear it. It sounds like something.
Yeah.
It's possible that.
Now,
Are there 2 HDMI slots? Because it's possible that slot's going.
so I know Kristen put it in the share box. If you guys wanna, we can keep moving.
Yes.
Oh,
Please go
okay. Unless you have a CD.
Oh, no. Yeah. Oh, yeah.
No, just.
No. So I could, yeah.
Okay, and this slide has everything that we just said in the several slides, right? You have that arrow, time from transplant, the first 30 days, you have the nosocomial derived infection, donor derived, and then in the middle you have your opportunistic, and at the end you have your common and the zebras, and then below it you have things that you may consider during each period of time. So rejection at any one point and use of anti-rejection therapy, that's a very ill patient, patients who are neutropenic, and patients who have active CMV disease.
If you want to keep going, I'll see if we can switch computers to mine and see if that helps.
Okay.
How good is your vision?
You
We can use this just now.
want to use that? Okay.
You have one?
My suspicion is it's the age damage.
Okay, Brian Bobby.
Every day.
It's gonna be a good one. Next month. I heard you got a call last night, very serious.
Oh, I got a lot of very serious calls. The nurses need to wear eye protection. I've got my very first, I got pseudomonal aspirate in my face. So they were like freaking out and I'm like, wash it off. I'm like, take a bunch of sterile water and like, I was just like,
Oh no.
uh-huh.
Did I just do
Oh,
that?
wow.
I'm
just like-
Pneumonia in your face.
Yeah, they're like, oh yeah, I guess they were like getting aspirate and just like it was flash in their face because they're not wearing eye protection.
I would have started with that.
There you
First,
go.
I was about to say, if I was suctioning somebody who had like gross stuff, I'd be like,
yeah.
Yeah.
Jesus.
You had a
What do you do about that?
that wasn't that like that, and that was during no, this was during daylight hours. It was just a little chat, and I'm just like, just wash out your eyes, it's fine. I'm just like, just, and they're like, oh, that okay, they feel better. I'm like, I'm glad. Like,
All right, guys, moving on
Yay.
to some of the immune suppressive drugs that are used. And, as we said earlier, any part of the immune system can be affected, but there are certain associations. And Dr. Montero, definitely feel free to add from, because I guess you see a lot of those from the antibiotic stewardship lens. So antithymocyte globulins, the ATIGAM, these are T-cell depleting antibodies that are given as part of the initial regimen to induce the immunosuppressive status. And T-cell, so a lot of herpes viruses, the CMV is very notorious with ATIGAM use. You have to prophylax for it, but also has non-infectious SARS kind of syndrome. They have a lot, certain cytokine release, they can be febrile and so forth. So it's kind of very tricky to decipher, but this is a serious immune suppressive medicine and usually virus, especially CMV. Steroids, very high doses of steroids are used. Any bacterial infection can happen, but once they start taper, you hear PGP. That's the association. So they've been high dose of steroids, things are being tapered, they're getting symptomatic, think PGP. Typically they get prophylaxis, right? But, even prophylaxis is not 100%. And again, compliance. Molds down the road. And then reactivation of previously kind of controlled chronic hepatitis B and C. They can have fulminant hepatitis. And of course, if the steroids are prolonged, you're going to have issues with wound healing and so forth. Azacyprine, Imuran, I don't see it used as often, but it's an antimetabolite that causes neutropenia. So just like your regular neutropenics, but also there is this association with flourishing of HPV if the recipient went in with a human papillomavirus infection. Cell-sept antimetabolite that causes neutropenia and B-cell suppression. So all your neutropenic stuff, early bacteria infections, translocation, but also play a role in late onset CMV. Cyclosporin, tacrolimus, which is Prograf, increased level of replication of It inhibits B cells, so you have a lot of viral replication, intracellular pathogens, any intracellular pathogens all the way to tuberculosis. Rapamune, some association with a lot of respiratory infections, and even without respiratory infections, it also has some kind of lung side effects. So they call you, patient has chronic pneumonia, whatever. It may be the drug itself or superimposed respiratory infections. Belatacept, this is a T cell co-stimulation blocker, notorious for EB virus reactivation and lymphoproliferative disease, CMV. Rituximab, anti-CD20, B cell depleting. So common things are hepatitis B reactivation. So if a person goes in with chronic hep B, got them rituximab, not on prophy, or even if they're prophy, sometimes they can get acute hepatitis flare. And then Solaris, which is a terminal complement system inhibitor, gives you your classic terminal complement system inhibitor problems, encapsulated organisms, including Pneumococcus, Haemophilus, and Neisseria, and we do prophylax. Dr. Montero.
Go back to this first slide. The other thing you need to know about all these drugs is not necessarily what she was talking about, the infections related to it, but their most common side effects when administered. The first one, anti-actin. What's the two most common things you think about? Fusion-related reaction and thrombocytopenia. Number two, glucocorticoids. You guys should know that. There's so many, it's ridiculous. Number three, azathioprine. She actually has it here. It's bone marrow suppression. Most common. Number four, cell-sept or amycophenolate. She doesn't have it on there. What's the most common side effect of this? Guys, you should know this. The reason they go to azathioprine instead of cell-sept is because of GI side effects. Nausea, vomiting. Those are the reasons they switch off. Cyclosporin and tacrolimus, you guys should know this as well. It's nephrotoxicity, but they also have gingival hyperplasia. They can actually have some effects on glucose. Next slide. Sirolimus, or rapamycin, not sirolimus, but rapamycin. What's the most common side effect? You guys should worry about. Why would someone switch off of rapamycin?
See, I told you, he's a drug guy.
The common thing is, if they're thinking about surgery in the future, it's wound healing.
Yes.
Horrible wound healing. So they actually, if they know they're going to be in elective surgery later on, they'll actually switch off. They have to switch off a long time ahead of time. If you're on rapamycin and say you have diverticulitis, go to surgery, you have high risk complications, but you have to have your surgery.
Is this a drug they would normally put someone on immediately post-transplant with the thought that they have a wound already?
Actually, they used to do it earlier on in some organs because they wanted to protect your kidney, so they use that instead of your tacrolimus. However, they tend to use it later now. But it's usually a cyclosporin or tacrolimus-sparing agent.
Gotcha.
And I don't know enough about that to really know exactly when it's used, but that's the time period. I'll skip to the next one, but rituximab, you guys should always, Hep B's got to be the first thing you think of in your mind there. But other things like TB and other things. And then includes she mentioned, if anything, it's not serial agents, it's terminal complements. So you need to know why sometimes the transplant doctors switch them off. You don't see much Immuran because a lot of people use more cell-sept, but some people just cannot tolerate that, and that's why you'll see Immuran. That's the only time you'll see Immuran really used. You got to understand why they switch off. I think it drives me bananas why they switch off prophy. The high potassium and etc. or the pancytopenia, either the Septra or the valicides. You have to know our side effects of our medications as well. Because many times our consult is not necessarily about infections, but because of side effects issues. So we had to understand what they're thinking and why they switched them off those therapies. One of the questions, we can't go after some of these side effects I talked about. You have to know your ID, but you also have to know the stuff that your primaries, the reason they're switching off a medication or another. Thank you. I'm sorry.
No, perfect. Because people get dumped on antibiotics and all that, and Dr. Montero had to review all these, so I think he's very familiar with these side effects. But also, something very important is the drug itself. What side effects does it cause, the GI and all that, and then the infection part of it. All right, so moving on to frequency, type of infections, sources of infections occurring in the first year after transplant. So what is the likelihood? This is, I think, from Mendel. Most of these thing is actually from Mendel, but some graphs from CDC are up to date. So type of transplant, if you see kidney, heart, lung, heart, and liver infections episodes, almost everyone will have some sort of an infection episode. Now, who are more likely to get it? People who have the lung, maybe over 3 episodes a year. What organisms? Usually bacterial, but especially liver, when they come in, it's usually like a bacterial infection. If you look down, the bacteremia incidences highest in liver. CMV disease, it occurs in almost everyone, but as you can see, lung and liver, maybe heart, lung, and liver. But lung is a big one that you have, to think about CMV when they come in like fever or things like that. Fungal infections also can happen in any type of transplant, but as again, you see lung, maybe people who have lung or heart lung. And then the most common source of infection, I found this very helpful. That's where I usually start. For kidney, if they come in with an infection, look at the urinary tract. For heart, look at the lung. For heart, lung, or lung transplant, look at the lung. And liver, look in the belly. That's like, just start there and then go, because the likelihood, the area where the transplant happened may be the source. Start there, but you will have to look, of course, very well. Looking at mortality data, I believe, deaths due to infections, in transplants. Overall, there is a downtrending tendency. So this is good. Over the years, mortality has improved. But if you see, again, the green light is lung, who's more likely to die from infection, lungs. Infections complications, as we'll see in lung, when they have these recurrent infections, then the graft becomes bad. So it's directly to infection, but also maybe related to infection episodes. So lung, heart, liver up there, and then of course the people who do overall better are kidney regarding mortality. So what are some of these general principles approaching a transplant recipient who may harbor an infection? You have to remember they have an impaired inflammatory response. So fever may or may not be present. You're going to have high index of suspicion with any presenting symptoms to make sure is this due to infection or not. So many times you may see a lump or may see an infiltrate or something in the lung and not a lot of other symptoms. And actually we would proceed on the workup, and they're just more likely to get biopsies and things like that early on if you have a suspicion of infection compared to immune competence. So if you see something that's not clear, that may be the next step to go to. They have altered anatomy when people get the kidney transplant or the liver rerouted and all that. The anatomy is not what you classically think of. So a pain over to this side may still be related to kidney or liver. So we tend to get imaging maybe a little bit earlier just to see what's going on, if there's an abscess, and where is the infection, if you're thinking infection. Also, they are more likely, as we mentioned earlier, to have issues with resistance. So if they're obviously very sick or febrile on your selection of regimens, absolutely, well, like all, our patients, look at their history, look what they've had before to select the antibiotic regimen that's appropriate, more likely to succeed before your culture data. When it comes to management, it can vary, of course, but these people may need a little bit more intervention. And if they have they may need surgical drainage, they may need just more removal of part of the graft, or so. Always look at is that the issue treated only with antibiotics, because you may actually need more than that. And then the other big thing with them, and I think Dr. Montero touched on that, is our antibiotics and the immunosuppressive regimens. It's not always easy to pick what antibiotics, and you always have to talk to your ID pharmacist, transplant pharmacist, and make sure we're not interfering or creating side effects with antibiotics, certain antibiotics. So The other big concept is that we know they're all immune suppressed, and one of the weapons you can use to control the infection is put them in a better immunologic status. As I said, it's very hard to know how much they're immune suppressed, but look at many times transplant doctors will do the drug levels just to see how high and how or how low, and then the recommendation always, you can have a discussion with the transplant team if there is any way to reduce this immune transmission to help you clear the infection. Last but not least, many of the non-infectious syndromes around medications and transplant and fevers and inflammatory response and rejection can mimic infection. So it just complicates everything, right? Because you have the lung infiltrates and the fever and this and that, and or the non-healing, ugly-looking wound, and they're on rapamune, or they suffering from a rejection episode. So I find that working close with the transplant team and having these discussions and conversations with the transplant attending. I respect all providers, but you really need to talk with the transplant attending to figure out what else from their perspective can be going on. Right, so now we'll quickly go over some of the common infections in each organ. So kidney transplant, where we already kind of spoke a little bit about that. The most common site of infection, kidney, urinary tract. They say by year 3, almost half of the people with kidney transplant would have a real, actual UTI. Recurrent UTIs may lead to worse long-term graft function and survival, including things like refluxes, strictures. We usually, when urine infections happen, UTIs happen in kidney, you want to treat appropriately, you want to treat aggressively. By definition, this is a complicated UTI. The question of asymptomatic bacteriuria comes quite a bit. I think every transplant center do something different, but up to my knowledge, and Dr. Montero can pitch in, usually the first 3 months after transplant, that's when they're doing surveillance and treating asymptomatic bacteriuria. ID may not even see these patients during this time, but it seems
correct.
Huh?
Where you both with state is correct.
Asymptomatic bacteria is common in kidney transplant recipients, and there are yeah.
We don't know.
So we don't know the answer. We don't know, but in TGH, that's what I think they do. They kind of jump on asymptomatic bacteriuria, but is it really the right thing? Do we do this for a good reason? We don't know. After that, though, I can tell you they usually don't do that. There's no surveillance. It's just based on symptoms, and it goes back to how you generally treat UTIs in other individuals. All right. Now, the zebras. They will get regular UTIs and ESBLs and the usual, but be very careful if you're going to have uncommon urinary pathogens, things like tuberculosis. And I can't talk enough about tuberculosis. It's just a great mimicker. It's that the diagnosis is delayed. Please have it in your mind, in your immune suppressed patients, your transplant, always think, can this be TB? And take a closer. Mycoplasma hominis is another one. Histo from people who from endemic areas. And then funky things like adenoviruses, but it has the classic presentation of hemorrhagic cystitis, bloody urine and painful. BK virus, it's not an infection per se, but it can affect the graft itself. So BK virus are latent viruses. They sit in the kidney, they have no problem. But once the people get immune suppressed, they wake up and start causing trouble. So if there is a whole lot of immune suppression and you see the kidney function is not good, people are having low-grade fevers, the urine is clean, look at BK virus, and it's one of the viruses that actually also in that first 3 to 6 months is being undergo some surveillance, see if they have significant BK virus viruria. Again, when is it just shedding and when is it just disease? It's really has to be individualized. Not everybody with positive BK in the urine has a problem, but it can be used as a marker of the degree of immune suppression.
That's what they do. So most programs have something as an outpatient where they check those routinely at some point. And if they start popping up positive in the urine, they don't introduce their immune suppression. They have to, or else they're gonna get in trouble. And you think you're protecting an organ, but you're actually making it worse.
So the hemorrhagic cystitis that you see with BK virus, is that more with the bone marrow transplantation?
Yes, actually, yeah. I think incidence-wise, it's more on the severely immune-suppressed Moffitt patients. I personally have seen probably not that many in total, but the ones we've seen, I've seen at Moffitt, but it is reported in the kidney transplant population who are overly immune-suppressed.
Okay.
Yeah, but you will see,
It's rare.
chances are, if you're gonna see an ad, the hemorrhagic cystitis is gonna be at Moffitt.
Gotcha.
Yeah. But TB, I cannot even tell you, we treated so many kidney tuberculosis that it becomes like, it biased my view, because anytime, we see a problem with a transplant or a kidney, I'm just checking for TB. I mean, this thing happened.
Are the TB cases that you're seeing when it comes to kidney transplant? I mean, these people are screened ahead of time to see if they have TB. Are they coming from potential reactivation of latent disease that we know they may have, or is this like more primary TB that you're saying?
So both, I want to say the cases we had is one lady had her transplant outside United States and she was never checked or screened for TB. So we think she's a reactivation, but we had a couple that we think is probably donor related.
They don't screen the donor?
That's a huge discussion. They don't screen donors, and we,
Takes too long.
yeah,
Oh, you have your organ, let's put it in.
yeah.
Well, it'd just be one of those things like.
Prophylaxis.
Don't get that.
Yeah.
Well, no. What I'm saying is why not send that to the lab and then you'll at least know your donor status instead of guessing later.
Yes. So I think eventually we'll go there because of the amount of tuberculosis that is seen in this population, that people may just have to admit that the test is not great when people die. It's not a cadaveric. The way the quantiferon or the PPD is manufactured, that it is really all about immunity. So you have to have immunity and somehow intact functioning living cells.
Too close to death.
Yeah.
Okay.
So the manufacturer never said it can be used because of the questioning reliability.
Gotcha.
Now, what else do we have? We have nothing. I said in meetings, let's send it, and if it's positive, we trick it, I took positive, and do something about it. If it's negative or indeterminate, hey, that's what we started with.
Right.
But there, I think it's eventually going to be either the manufacturer gets some studies or modify the test so it increases its sensitivity and specificity to acceptable levels. That being said, in places who are more endemic of tuberculosis or have a higher incidence in the United States, part of their prophylaxis is actually INH. Yeah, not here, but here people are still, we do screening surveillance before transplant and they go in prophylaxis. It doesn't contraindicate transplant, but they have to take prophylaxis. And then yearly thereafter, just like you would do for your HIV patients. When the infection happens outside the kidneys, your common offenders, it's pneumonias and wound infections. And when people have trouble with wound infections in a kidney transplant, these are your usual poor healing. They're uncontrolled diabetics for some reason. They had multiple operations, obesity, and then people who had some sort of injury, urine leaks. Because surgical site infection with kidney transplant is rare. But so I would start there. I'll start the urinary tract, look at the lungs, look at their wounds, and if you still can't find things, that's when you really take it to next level. We said that already. If you have recurrent infections, and this is true for all organs, you will end up affecting organ function. So you're going to have to and have that conversation about if excessive immune suppression leading your recipient to have recurrent infections and so forth. All right, moving on to heart transplant. Where would you think the commonest site, probability-wise? It can happen anywhere, but pneumonias, bacterial pneumonias, followed by things like UTIs, herpes reactivation, specifically CMV, and then invasive fungal infections. Please understand, things on the slide is just by probability. The list is very long, and you kind of have to be conscious. But I just wanted to review like the common or more frequent offenders. Okay, look in the lung. If you see something you don't like, pursue it. Find out what's going on, because the next thing you know, it's a big mucor or something of that nature. Incidence of pneumonia after heart transplant is highest in the first 6 months, and I think this is from up-to-date surveillance of 620 heart recipients, transplant recipients at Stanford, showed that infections were the most common cause of death, unfortunately. So that's what they said. So we have to kind of fall on us. This just gives you an idea. So gram-negative pneumonias, you may not really think of gram-negative as but you know, they happen, followed by Staph aureus. Aspiration is a big issue in people with thoracic surgery. And as a matter of fact, if they are prone, especially lung transplant, to have recurrent aspiration, they get that fixed first, okay? And then think about Aspergillus, Legionella, and Toxo in heart. Not gonna go through that. Now, there is unique complications after heart transplant in certain individuals. This is kind of unique in type of infections to thoracics. Mediastinitis. They'll have very high fever and maybe pain, and you think maybe it's the wound. Scan them. You may see evidence of mediastinitis. Their surgical wound on the top may look kind of benign, but they still can have surgical wound infections, and this will need debridement. Staphylococcus aureus, specifically gram-positives in general, are the most common pathogens, but we have seen unusual organisms like Mycoplasma hominis, Legionella, Aspergillus, mucor, nocardia. I personally had Aspergillus, which was very, very difficult. Nocardia, look at the names. You're going to see these coming again. Factors that predispose to mediastinitis, so you're more worried about people who have repeated operations because of hemorrhage, people who they jack up the anti-rejection because of cardiac, and then of course diabetes is always a risk factor. Very important, if that's your suspicion, to talk with the team and make sure appropriate debridement takes place. And of course, intraoperative cultures are the best. Another unique complication to thoracic or heart transplants is some of them may have gone to transplant with what we call Lvads, and they may have a chronic driveline infection. So this will not really contraindicate transplant, even if it's like active. And they had that guy I was involved with, he had Aspergillus. They still in the driveline, they still took him to transplant, because the idea is that you're going to evacuate everything, right? You're going to remove the heart, you're going to remove the LVAD, and you're going to wash really good, and you're going to put a new graft. But they are at risk of recurrence of the same organism. So it's challenging. Many times they're drug resistant, so it's a nightmare, but it is something that if you're seeing a heart transplantation and they had this phenomena going on, to be conscious that this may be a side of trouble. Unique organisms, well, not unique, but organisms related to heart more often. You need to be aware of Toxoplasma. People may not take the prophylaxis if they're positive. This is something that we screen and prophylax for. So toxoplasmosis, nocardia, and Chagas. This is like a heart thing. So toxo can be acquired from organisms encapsulated where in the heart, encysted from the recipient, or it can be a reactivation. It causes necrotizing pneumonitis, myocarditis, and even pneumonitis. So encephalitis. So toxo is one kind of unique thing that when you have a heart person with problem, heart lung, keep that in mind, look for it. Yeah, it is uncommon if the person takes the prophy for PGP, because Bactrim works against it. But I mean, it can happen, and especially if they don't take the prophy. Nocardia, you will also see that in chest transplants, heart, lung. They're very characteristic, right? They have the nodules, and it tends to go to the brain. Just to know, if they take a biopsy, it is a modified acid-fast filamentous organism, so that gives you a clue early on. But these are just examples of how it will look in a path, lung path, and CT, and then the gram stain. Last but not least, you want to keep in the back of your mind is Chagas disease caused by Trypanosoma cruzi. People from endemic areas, actually, I was just talking to one of the cardiologists, and he said some of his heart failure patients who are not necessarily born in endemic areas, but their parents are from endemic areas. They move to United States. They can have congenital. Yes. So it's something that we typically screen for, and we have a big, alert for it when somebody is from endemic area. But people who, their parents or originally from the area, it can still happen. So keep an eye on Chagas if you have myocarditis post transplant. The heart is going big, you have fever, you don't know what's going on. You can detect it, the parasitemia, by PCR, and that is used to monitor therapy and so forth. So screen in the appropriate patients and keep an eye if the person have risk factors or have unexplained myocarditis. One more thing I just want to highlight is something called cardiac valvopathy. So when people go heart transplant, they get this initially at the beginning, a routine of like biopsies, I guess. So that creates some sort of a valve disease, and that predisposed them to endocarditis. And heart transplant is one of the categories that we prophylax against endocarditis, especially if they have evidence of cardiac valvopathy because of chances of endocarditis. So a heart transplant patient with some sort of valve problem, absolutely prophylaxis for endocarditis. And then, when they get endocarditis, it can be a regular bacterial, but can also be something very funky. Imagine they go in there, so contamination. There are reported cases of Aspergillus, Legionella causing endocarditis. All right, moving on to lung transplant. Again, most frequent site of infection is the lung. During the first few weeks, you see the mediastinitis, then, you can see invasive fungal CMV disease, CMV pneumonia. Again, multi-drug resistant organism colonization can be a problem. We typically screen or try to understand what was the pre-transplant colonization microbiome looks like. This is worse if they're getting a single lung transplant and you have the colonized bug sitting on the other lung, so they can get in trouble. So that's the first place to start. Is it a single lung, double lung? What was the previous organisms? What was the donor organisms? And that's where you start kind of your workup. They are prone to have invasive fungal disease, invasive mold, especially aspergillosis. And we use prophylaxis for lung. Different centers have different protocols, but when we talk about screening and prophylaxis, we'll go over the TGH protocol for prophy for fungal. So mediastinitis, CMV, if there is a single lung, multi-drug organisms, and then the molds, especially Aspergillus. Mucor too, my case was mucor. I usually keep a separate slide for CMV because it's a frequent offender, sometimes can be really hard to deal with. And again, Dr. Montero, your domain, jump in on CMV. The CMV, the spectrum of disease is big, right? You can have, asymptomatic shedding, you can have mild illness, you can have severe, and you can have something that severe enough to potentiate rejection. By time, you will get to understand which spectrum of this CMV disease or infection the person in and act appropriately. How do you detect it? The CMV quantitative PCR in the blood can be a marker mostly to monitor treatment. Very hard to use it to diagnose. But if you see lung problem and you worry about CMV, that's a lung biopsy kind of situation because, you may not need to, if there is lung infiltrates, a high CMV viremia, most people will start treatment, but I think they do have a low threshold to biopsy if you're wondering about if that's the cause.
I'm not sure the biopsy much anymore. They belongs in, but they have a high viremia, they're going to treat.
Yeah, they treat. Absolutely.
They'll do it for maybe other sites, if you have esophagitis, you have other symptoms, yes. But they usually have a few wordings for that.
Yeah, I guess, yeah, if high viremia, you treat, they respond good. If not, then, you know, you move on the workup, but,
About to like
definitely.
rule out rejection. Get a biopsy.
Yeah.
Yeah, I guess they,
They'll do that for lungs, yeah, but they won't, that's not to be, they're not looking for CMV, they're looking for rejection at that point.
right. So if they fail, right, yeah.
It can be hard for health difference sometimes.
Yeah, they'll be able to see that, but
Advertise.
They never.
usually what happens, the lungs, when they get bad, if you could, all of a sudden their lung volume go down, they may have febrile illness, they may or may not have much of an infiltrate, so they'll body somewhere. But you know, may not be as targeted as you would like to believe it's targeted. And they'll get several biopsies, but most they're really looking for rejection
Right,
Right.
right, when they're biopsying.
for their biopsy. All right, I want to be clear about that. That's what I want to be clear about. If I accidentally find some other stuff, but they're really looking for rejection.
Right.
Yeah. And it does modulate rejection. I think that's why, especially lung people, are very nervous about like high level CMV viremia. That's why you can do preemptive, follow the PCR, and if it gets high, get these patients on treatment. And if you think the patient has an acute CMV disease, high fever and all that, and they are seronegative, you can use immunoglobulin. In cytogam, which is a CMV specific immunoglobulin, plus antivirals. Bearing in mind that this chronic valsite and all the VIRs, I guess, is the bone marrow suppression. So you're like, it's for me, these are the worst patients, and that's when I called Dr. Mati. I was like, this CMV guy is out of control. You can't control. You keep jacking up the dose of the cycle. Now your numbers, Kristen is calling the leukopenia is happening. So it's really, to me, these were some of my nightmare cases. But if they fail treatment, look for ganciclovir resistant. There is sequence testing that can be done to detect resistance. Foscarnet is the next therapy, notorious for renal failure. And then the new salvage therapy, that marabavir and etoramivir, I think you had one or two.
Only for therapy. You guys
Yeah.
might use this more in
Yeah.
aspect, but marabavir is a therapeutic agent, whereas the tonavir is a prophylactic agent. Can't do it the other way around.
It wouldn't be treated.
And when you're using the tonavir, you're not prophylaxed for the other viruses, the other herpes viruses. You gotta make sure
Specific.
you actually also cover your herpes viruses.
At what point do you think about cytogam?
Cytogam, listen, there's a lot of controversy with cytogam. Right?
Yeah.
So let's be clear.
Yeah.
The reality is, I think there's probably best evidence first time and it's seeming pneumonitis. So beyond that, it gets kind of
Maybe.
It's getting very hazy. It's very hazy. People use it, and I'm not sure how well it really works. People use it when they have resistant CME and they want to, they may not be able to achieve the phosphate level. Again, not very good data on that. But the reality is probably the best evidence in initial disease, when you acquired de novo primary disease, and pneumonitis.
Yeah, I think the couple of cases we used was seronegatives and pneumonitis, and then you're like just so desperate because you're pouring all these antibiotics, but it is kind of, you don't know. The last thing I want to mention about lungs, yes, prone to your regular viruses and all that, but mycobacteria, that's another one. Mycobacterium tuberculosis, Mycobacterium abscessus, atypical mycobacteria. You may get a lot of consults about MAC, and it doesn't contraindicate transplant. And actually, word has it that usually those who are just colonized, it doesn't really affect. It gets treated, it gets prophylaxed, but usually the bad news, of course, is TB and abscessus. So another thing unique to lung is, you can imagine they're bringing in these lungs and then they're creating an anastomosis in the airway. So sometimes there can be an anastomosis injury, and we had a case where they had a fungal aspergillus in the anastomotic area. So that's kind of something unique to lung as well. So when they do the bronch, they inspect the anastomotic site. And then eventually, if they do get recurrent infections, they go into this unfortunate and irreversible stage of obliterative bronchiolitis, which is a pathologic manifestation of chronic rejection associated with recurrent pulmonary infections. And it is one of the major causes of lung is not working well anymore. Lung transplant team has a protocol of BL surveillance to see what's going on early in transplant and then as needed if there are rejections and such. Very quick about liver transplant. Where do you think most of the problem will be?
Lung.
Abdominal, hepatobiliary, liver abscess, cholangitis. And then one thing I want to say about the organisms of liver transplant can be anything, but they have predilection to candida, candidemia, fungal infection. So actually, this is a type of transplant that an anti-candida treatment prophylaxis may continue for a bit longer. What predisposed them to graft infections, intra-abdominal infections, rejections, repeated surgeries, hematomas, iron overload, we talked about that. Management. So in general, just like any, I guess, infection approach, you always assess transplant infections if there is a site that need to be debrided or drainage. IV antibiotics, again, selection is very important. They may need a little bit longer if, case by case, but that's, difference from the regular. And then sometimes infection can be treated by retransplant, but it's, last but not least, COVID-19, our experience here has been that, it's generally bad news. People kind of, people who are sick to start with do very poorly. But data nationwide seems to say that the clinical manifestations may not be severe. They're generally similar to those with non-transplant. But I don't know, the ones we encountered here, they really had severe disease. Bear in mind that if they do have COVID, they may shed a little bit longer. And so isolation may need to be. What to do about immune suppression, people really don't know. But I guess the general approach is if they're overly immune suppressed, you want to address that. But this was a big question during the COVID pandemic and transplant. Well, we say that the problem with COVID is this completely dysregulated immune response, and it's more like immune injury than virus itself. But then you have the immune suppression. So it's a big question. I think it's still, the jury is not out. But I think for now, it can be treated like immune suppression handling in any infection. And then I cannot stress enough vaccinations. The use of immunoglobulin and all these things back and forth. But as of now, I don't think there is any immunity. Yeah. Sorry that I took few more. I know it's 9. Any questions?